Director Eagleson, welcome. We're just waiting on, hi there, waiting on Ms. McCullough to get started. She's going to do the roll call for us, and then we will get started.
Somebody in the chat.
Good morning, everyone. I will begin the roll call at this time. I'd first like to welcome our newest MAC committee member, Dr. Nash Ahmed. Dr. Ahmed, if you would please verbally acknowledge your presence, we would appreciate it.
Good morning, ma'am. I'm here, present, and ready to attend the meeting. Thank you.
Thank you. Alejandro Clavier. Andrea Daines. Dr. Thomas Huggett.
I'm here.
Mr. Arnold Cantor.
Here.
Mr. Marvin Lindsay.
Here.
Miss Ann Lundy.
Good morning. Here, present.
Mr. Howard Peters.
Morning.
Amber Smock.
Here.
Kai Tail.
Good morning.
Nellie Vasquez Rollins. Samir Vore.
Samir Vora, present.
Dr. Whitaker.
Present.
And although she's not an official MAC committee member, I want to make sure that Kathy Chan is on as well.
I'm present. Thank you.
Hi,
Thank
Kathy.
you. You have a quorum, Madam Chairman.
Thank you so much, Ms. McCullough Stark. First, welcome to Dr. Ahmed. Thank you for joining us today. Dr. Ahmed, can you just give us kind of a minute about yourself, kind of what part of the city or the state you represent, and work you do in Medicaid?
Sure, ma'am. Good morning. So currently, I'm the COO and the CFO at the Little Rock Hospital. About 85% of our population is a Medicaid population, and we service currently right now the west side of Chicago.
All right. Well, thank you and welcome to the committee, and I'm glad you're able to attend the meeting. Next, we'd like to introduce the HFS staff who are with us today. Director Eagleson has joined us. Director Eagleson, can you lead off these introductions?
I can lead off, and I know there are a multitude of staff that are with us, and I'm grateful for them all and all the work behind the scenes, not only for this meeting, but for all the significant projects that we have going on. My name is Teresa Eagleson. I'm the Director of Healthcare and Family Services. With me here, front and center in this meeting are Kelly Cunningham, who is our Medicaid Director, and Kimberly McCullough Starks, who's our Deputy Director for Community Engagement. Kim, do you want to should we let each person introduce themselves, or would you like to read the list of all the staff who are participating on the meeting today?
It's your preference, but we have roughly about 30 some odd staff members that are a part of this meeting this morning. I'd be more than happy to read the list.
Okay, maybe we will just acknowledge them all and thank them all for their participation and let them introduce themselves as they speak. So, and their names will be reflected in the minutes. So thank you, Team HFS.
Well, Director Eagleson, thanks for such a robust presence here today of your team. That means I know you have tons of work to do. That means they're not working on everything right now, but it's great to have you all touch base with the state on this work, on your work. So we're delighted to have you today, and we'll recognize folks as they come forward. So thank you for that. Has the committee had a chance to review the minutes? If so, I'll take a motion to approve.
Move for approval, Madam Chairman.
Second?
I second.
All in favor? See your
Aye.
pictures.
Aye.
Aye.
Thank you. Any opposed? Okay, thank you. The minutes are approved. Ms. McCullough Starks, can you lead us off with public comments, please?
Sure. I am going to read the name of the first public commenter, and then I'm going to ask that Sharice elevate them to a panelist status so that they can unmute themselves, and they will then be allowed to speak on the panel. And the first panelist is Dr. Green. Dr. Green, if you would please unmute yourself so that you are allowed to speak. Dr. Green is the co-founder and CEO of Family Christian Health Center here in the city of Chicago.
Good morning. Can you hear me?
Yes.
Okay.
Yes, we can.
So would you like me to start then? I'm sorry.
Yes, please.
Okay. Good morning. Then Dr. Joy, who is with me this morning is also Dr. Catherine Hart and Dr. Joy West. Thank you so much for this opportunity. So Dr. West, if you would like to begin, please.
So Dr. Green, we're starting with you. Dr. West and Dr. Hart registered as public speakers independently, and each of you will have 3 minutes to speak. And so if you would like to begin with your comments, we will start with you.
Okay. All right. I will. So what I would like to have to say, and thank you so much for this opportunity, is that as we now know that in Illinois, that 6 times difference rate of death among women in the Black communities. And so as we begin to look at how we begin to pull this back, there are things that we realize that could make a huge difference in those outcomes. And the things that we are referring to include the following. 1, tracking outcomes that have been impacted by women that have been affected by the closures of the hospitals. What we would do is that data, what we are calling for is that data would be used to determine where they delivered, their clinical outcomes, and to review their Medicaid claims. We would also then like for additional funding for the Southside hospitals to remain open to adequately care for the mothers and closures and close to their homes. Next, we're also calling for a moratorium on future closures. However, if there are closures, create an immediate plan for follow-up care that is shared with the patients and referring providers before the unit closes, so that there is adequate time for people to prepare. Next, a mechanism for sharing prenatal and delivery medical information, ideally by a shared EHR or a path to interoperability between disparate EHR systems. It's very difficult for providers to get information for patients who just show up and they don't have access to those records. That data and that information can be life-changing for us making an impact on the poor outcomes that we're having for Black mothers on the South Side of Chicago. Next, we would like implicit bias training for the staff, physicians, and researchers who care for expected mothers in Cook County and Illinois. Funding for an independent review of clinical maternity and newborn data and impact of COVID-19 to develop short and long-term strategy with the input of Southside and South Suburban provider groups that would create a plan beyond that of an individual institution. It's a problem that we all own, but we're doing them in silos. And so to have the ability to network that together, to be able to make better outcomes that are equitable for all of our patients. Next, partnerships with hospitals, legislators, policymakers, insurers, and community advocacy organizations like Black Girls Break Bread to highlight community awareness and facilitate actions to improve communication, advocacy, and healthcare equity. And in summary, what I'd like to say is that the delivery and coordination of high quality, accessible obstetrics care can't be an afterthought when the cost to our communities is so high. The United States has many of the most sophisticated and medical systems in the world. We can do a much better job for our mothers and our infants on the South Side of Chicago. That care should not be determined by the zip code that you live in. Thank you very much for the opportunity.
Thank you very much, Dr. Green. Our next public speaker is Dr. Catherine Hart. Dr. Hart, if you will yourself, you have 3 minutes to address the committee. Thank you.
Okay, can you hear me?
Yes, we can.
All right, so I will put on record that you sort of threw a wrench in our plan. I'm Dr. Catherine Harth. I'm part of the Southside Obstetric Synergistic Collaboration. I've been obstetrician. I've been practiced on the South Side of Chicago for over 30 years. And I'm going to change because it makes more sense, Dr. West, so I'll do it this way. I'm going to do the introductory and Dr. West will do the closure. Thank you for the opportunity to speak on the closure of labor and delivery units on Chicago's South Side. Physicians on the South Side of Chicago are sending an SOS to you, policy leaders, and city and state agency officials. Before the pandemic, according to Chicago's Maternity Morbidity and Mortality Report, the rate of pregnancy-associated deaths was nearly 6 times higher for Black women than white women. The risk to Hispanic women is twice that of white women. The majority of these mothers who died during childbirth lived in under-resourced communities. The COVID-19 pandemic has further exposed the gaps in healthcare access for pregnant women and infants of color and directly increases the risk of adverse pregnancy outcomes. As Black physicians, we are advocating on behalf of our patients regarding the closures of an alarming number of labor and delivery units in recent months and years. The OB unit casualties on the South Side and South suburbs over the past decades have been dramatic. First, Providence Hospital in 2010, followed by Jackson Park, Metro South, and Holy Cross in October of 2019. In the wake of COVID-19 pandemic, St. Bernard closed its OB unit in early 2020. Advocate Trinity Hospital labor and delivery unit temporarily closed, but has since reopened. That ends my part of the comments that we as a collective group, Dr. Joy West, who is going to hopefully speak next, Dr. Lisa Green, and I as spokeswomen for a larger group of concerned African-American providers of healthcare who practice and live on the South Side.
Thank you so much, Dr. West, for your comments. We're going to now, at your request, we're going to have Dr. Joy West to now be elevated to a panelist so that she may provide closing remarks on behalf of your consortium of speakers. So thank you so much. Dr. West, please prepare to unmute yourself and address the audience.
Hello, I believe I'm unmuted. Thank you for the opportunity to continue the public comments around the closure of labor and delivery units on the South Side of Chicago. So the potential closure of Mercy Hospital marks the latest tragedy in access to maternal care. With an estimated 300,000 reproductive age females within these Illinois hospital planning areas, the remaining facilities which provide obstetric inpatient services include only Roseland Community Hospital, Trinity Hospital, and UChicago. These are the only 3 facilities providing OB care inpatient on the South Side of Chicago. With limited advanced awareness of the closures, the remaining facilities and communities lack adequate planning time or resources for transition of services for pregnant women to their facilities. Now, given the existing alarming maternal and infant morbidity and mortality rates in Chicago for Black women, obstetric unit closures will likely increase poor outcomes. Further, we know that pregnant women with COVID fare worse. They have slightly worse outcomes when impacted by the virus than non-pregnant women. So in summary, Dr. Green and Dr. Harth and I are calling for attention to the alarming rate of closure of labor and delivery units on the South Side of Chicago. Thank you, Dr. Whitaker and members of the Medicaid Advisory Committee for the opportunity to elevate this very important issue. Thank you.
Thank you so much, Dr. West. We had one additional request for a public comment or a question actually that is being asked of the department, Madam Chairman. So I'm going to ask my colleague, Laura Phelan, to unmute herself so that she might share the questions. There are two questions that are coming from Bridget Leahy. She will read the question and the department's response. We were asked to provide the answers to this question live during the meeting, opposed to the individual posing the question to the committee. So Laura, if you would please unmute yourself and address the committee, we'd appreciate that.
Sure. Hi, this is Laura Phelan. We received some questions on the family planning SPA from Bridget, and I'll read those out quickly for you. Sorry, I had the response up, but not the questions. Okay, so the questions were, was there a determination of FPL with the new Biden administration? Is there any room to revisit FPL income eligibility to further expand access? It would be optimal to have income eligibility based on individual income so that anyone 12 and older can gain access to benefits without reliance on a parent, guardian, or a partner, especially in cases where good cause exemption would be relevant for those accessing family planning SPA benefits due to concern for their physical or emotional harm. And consistent with Illinois law, minors can independently seek certain confidential services such as STI and contraceptive services. This additional coverage should be coordinate with this law. Timeliness is a core tenet for accessing high quality contraceptive care. With this SPA, we ask that MPE be included to avoid any delays in starting birth control of choice. Without this inclusion, the window of providing voluntary preventive services is a great missed opportunity. There's one more. With regard to the family planning SPA, can HFS please provide an update on the submission timeline and the current content? It was previously shared that a preliminary review of the family planning SPA was done by CMS pre-COVID, and we are happy to hear that it is back in motion. We want to press upon a few salient points. So thank you, Bridget, for the question, and we appreciate all of the additional details that you put into the question. I just wanted to confirm that we are still looking at the family planning SPA, but we currently do not have an update on timeline or other considerations. It's something that we're looking at along with the difficult budget year that we're currently planning for.
Thank you, Laura. I believe that completes public comments. Ms. McCullough Starks, please correct me if I'm wrong, but we'd like to move on with the remainder of the agenda.
So, Dr. Whitaker, we have one additional public speaker who has been waiting to speak, and that public speaker is Renee Popovitz. Renee Popovitz is the general partner of Popovitz Law Group PC. So if we can elevate Ms. Popovitz so that she may provide her comments, you have 3 minutes to speak. Ms. Popovitz, thank you.
Good morning. Thank you for the opportunity to raise these two questions before HFS and the Medicaid Advisory Committee. The first one deals with a notice that came out as part of the Aetna's Centene transition. And in that notice, they indicated that the timeliness of filing requirement is still 180 days. Yet in the provider notice that was issued by HFS on March 20th of 2020, there is an express relaxation of those standards that extend the 180 timely filing limit to 2 months from the end date of the public health emergency. We'd just like to seek clarification as to that being in effect, and there really is not a timeliness of filing requirement, and also to know, does it apply to dates of service during the public health emergency or any claims that were pending at the point of the public health emergency? So that's the first question, and I don't know the protocol for you answering it, but that's the first one I'd like to get on the record. The second issue deals with the Medi system. I've been dealing with this issue since about 2016, but it seems to be getting to a critical point because I've noticed even in some of the Community Behavioral Health Association information that there are a lot of providers that are having issues with eligibility denials. As you know, the providers, the only system we have to confirm eligibility is the Medi system. We rely on the Medi system. And yet HFS delivers an 834 report, which is required under the code set transactions to the MCOs. I was under the impression it was on a...
Joshua.
Pardon me?
I'm sorry.
So the HFS delivers an 834 report to the MCOs that clearly states eligibility and what population they're in. The Medi system has a section in it that has exclusion codes, yet no one seems to know what those exclusion codes mean. If you look at the 187-page manual, there's no explanation on the exclusion codes, and we don't know if someone is limited to a particular population. So if the Medi system says that someone has full Medicaid coverage and we don't know if they're in the ACA population versus the FHP population versus a CHIP population, whatever, we have no way of knowing that someone might not be eligible for that particular service. This is relevant because the providers are checking that system, relying on that system, rendering the services. The patients are getting the care. The state is benefiting from those patients getting the care. The MCOs are being paid their PMPM, and then they're turning around and denying it because they're relying on an 834 file that says it does not cover what is allowed for that population. And I think
thank you so much for your question. You've reached your time. And so I am going to turn over to my colleague, Tracy Keene, who is prepared to address the questions that you've posed. In addition, there may be others from the HFS team that may chime in to assist her in answering the very comprehensive question that you've posed. I would ask that I would say just in the interest of time, my colleagues are going to be brief with the answer here today. We have no problem in following up with you, and we'll make sure that all provider notices are updated to make sure that there's clarification around the challenges that you've posed here today. So Tracy, if you would unmute yourself and address her question briefly, we'd appreciate a response here. Thank you.
Hi, thank you, Kim. Can you hear me? Okay.
Yes.
Hi, my name is Tracy Keene, and I work for Healthcare and Family Services. And for those of you who have not seen me before, just to do a quick introduction, I am the new Deputy Administrator, the old Lynn Thomas. So good morning. To answer the question about the Medi, I would like to look at that for you and take that back because it sounds like you're having some trouble between the 834 and Medi and knowing when the exclusions will be applied by just looking at Medi. Is that a true statement, I hope, of your question? And so what I'd like to do is take that back and get the exclusion codes and see if we can do something to make them more valuable to you, if you will, get a better description. So I hope that will help, but I am going to need to take that back.
Great. Thank you
and
so much,
fully
Tracy.
The
Thank you so
Aetna,
much.
I think someone else would have to address. The Aetna versus the provider notice is, would that be Laura?
Actually, it's Robert Minzon, so I can address that real quick. None of the MCOs are granted an exception to that, so Aetna will comply. And your question on data service versus claim date, I don't actually know the answer. Data service is the cleanest way to do it, but we'll make sure to clarify that as well.
Robert, it's usually date of service, just as an
It should be.
FYI.
It should be date of service, right? I agree.
Thank you so much, Robert. Thank you, Team HFS, for responding to our public speakers' questions. Dr. Whitaker, I am now concluding the public speaking segment and turning it back over to you.
Thank you, Kim. As always, great to hear from the public. Very robust questions and engagement. I want to thank everyone for participating. Some very important issues brought up that we are encouraged to follow up on. I'm going to take Chair's prerogative, and I would like to move up on the agenda item 8C, which is a report out on the opioid use disorder withdrawal management subcommittee. And I'm going to ask Dr. Goyle to render that report. Dr. Goyle available? Dr. Goyle? Okay. Dr. Goyle. Is Dr. Goyle available, Ms. McCullough-Starks?
Dr. Whitaker, let me find out where Dr. Goyle is on the list. I'm sure that he is on the platform.
Okay.
Why don't we move ahead in the agenda in the meantime, and we'll come back to this report.
Sounds great. Director Eagleson, love to hear from you. We're particularly interested in following up on the healthcare transformation presentation from our last meeting. So thank you so much.
I'm so excited. Thank you, Chair Whitaker. And I'm so excited to say that our transformation proposal that we had highlighted for all of you at a previous meeting passed the General Assembly almost unanimously in the January session. Now we are looking forward to implementation of transformation. And this is really, as I was listening to some of the physicians from the South Side speak, and as well as others, this is really a unique setup for Illinois, especially in the Medicaid program. And we really want to put communities in charge of what they want to focus on in these transformation projects. We've heard many of you over time advocate for change quite effectively and advocate to reduce and even eliminate health disparities, bring about better health equity, and really change that particularly influences social determinants or influencers of health that have disproportionately impacted many of our communities. So this transformation process, which more information will be coming in the following weeks and even months, will allow communities and providers within those communities to come together to submit proposals that will focus around the projects that they feel are of most need in their communities. They will need to focus on at least one or more of our quality pillars that we'll be talking about in a presentation on the quality strategy here soon, and will be measured by their impact on whether we will continue to fund those projects. So really some opportunities to specifically have people, providers and customers engage at the community level for measurable impact and improvement, we hope. So there will be a lot more coming on the homepage, on the page on our website around transformation, and we may even give an updated proposal to the MAC committee if they would like that at the next meeting. So appreciate the time. I won't say more, but very, very excited about the project and opportunities before us.
Thank you. We look forward to hearing more. If we could hear, we'd like to put this on the agenda for every meeting, actually, and keep sort of following up on it. So, and thank you for posting the PowerPoint to the website. Director Cunningham.
Hi, good morning, everybody. My name is Kelly Cunningham. I'm the Medicaid Director at HFS, and very pleased to have such a good group on the phone and on video this morning. I really want to thank everybody for attending our meeting. A few more thanks before I start the HFS update and we dive into the agenda. I really wanted to take this opportunity to thank the HFS team for all of their hard work at all times, but particularly over the course of the pandemic. You know, we have a lot of just incredible people working in HFS, and I think we've all done a great job trying to come together to develop new ways of communication, new ways of getting tasks done, and really have developed a lot of respect for each other. And so I just wanted to kind of give a shout out to the HFS team publicly, as well as thank all the providers and advocates that serve the Medicaid population in the state. You know, we've been through unparalleled times in the last year, and we may have a little bit more to go. But I think everybody has really done yeoman's work in making sure that services continue to be provided to our participants and our customers. And on behalf of the Medicaid program, we cannot, you know, thank you enough. So I just felt I would be remiss if I didn't, you know, extend our appreciation to all of you. I wanted to bring up an item quickly that isn't on the agenda, but to bring it to the attention of the MAC and to kind of get everyone's thoughts and reactions and maybe lay out a strategy for moving forward. In the past month or two, it's come to our attention that there is a lot of interest in creating a new subcommittee of the MAC on community integration. Community integration would focus on increasing access to home and community-based services for our Medicaid participants and customers that qualify. Look at breaking down barriers to people getting the services they need to stay in their homes and communities. And, you know, really try to create an environment that promotes home and community-based services. So we've got a draft proposal that's been brought forward to us at the department. We're in the process of evaluating it right now. I think it has many strengths to the proposal. Some of you may remember from years past, we actually had a long-term care subcommittee of the Medicaid Advisory Committee that focused on nursing home, some institutional issues, some home and community-based waiver issues, but it really kind of went dormant after a while, and we haven't had a real concentrated presence or attention to these issues in previous years. I think has been said by previous speakers, and it certainly is known to all of us. You know, one of the things that the pandemic has really laid bare to all of us is, in some cases, the difficulties and danger associated with vulnerable individuals and individuals with disabilities living in institutions, you know, accorded, you know, to the COVID pandemic. You know, we've seen a very large number of deaths of individuals in nursing homes, and, you know, perhaps not through any fault of anyone, but I think if anything, that has really drawn attention to the fact that we need to ensure that people have alternatives to those institutions, and that they are alternatives that are high quality and meet the needs of individuals. That's something we've done through our 9 home and community-based waivers in Illinois. Those waivers go back to the early 80s in some cases. And I think, and we believe that we really need to make sure that this issue gets some concentrated attention, and the time to do that is now. So we'd like to, get people's reaction to this idea, hear what people have to say, possibly solicit some volunteers, and just get some reaction from people. So I wanted to do that. And then I wanted to just address one question. I believe Marvin Lindsay raised this with us prior to the meeting. I said I'd cover it in my update. Marvin, you had some questions about a project we call the pipeline or the clearinghouse. And I wanted to let you know we're beginning to, where claims are being processed through the clearinghouse. We do have some data on that, and that mental health and behavioral health claims are part of what is being worked through that process. And we have active participation from our managed care companies. So just wanted to cover that while I was speaking. Kim, I'm not sure the best way to get some input on community integration subcommittee, but I was hoping that we might be able to allow Amber Smock to speak on this if she wishes, or other MAC members.
Are there any MAC members? Yes. Are there any MAC members who'd like to respond to the proposal sort of being put forth by Director Cunningham? Amber, any thoughts from you?
Sure. Hello, everyone. This is Amber Smock, and I want to thank Director Cunningham for bringing up this proposal. As many of you know, certainly community integration and ensuring that people with disabilities and seniors who want to be able to live in community actually have access to it is a pretty critical issue. And there is a wide range of groups across the state who do not have access to any home and community-based services at all right now, or who have very limited access. And even though the state of Illinois is currently working on 3 Olmstead consent decrees, there is a lot of work outside of that, and the Olmstead consent decrees don't apply to every single applicable person with a disability across the state. So I think one of the goals of this effort is to try to identify where are the gaps and where are some opportunities. And I believe it is intended to be something that cuts across different disability or level of need groups. So that is important. And as a little bit of further background, I do believe with the new federal administration, we are going to see a very strong emphasis on developing further opportunities for funding, grants, enforcement for home and community-based services. So it seems opportune to try to get a sense of what is the baseline and what does Illinois actually need in order to empower HFS to be able to do the work we need to do and capture opportunity as possible. I also want to strongly emphasize that in the land of home and community-based services, there has also been very little discussion of racial disparities in access to HCBS. And in addition, access for people of varying immigration status. So being able to include that in terms of identifying further opportunities for people would be fantastic. So I am definitely willing to volunteer for this community committee, and I thank HFS for being willing to entertain it.
Are there any other committee members that'd like to comment on this proposal?
Hi, this is Nellie Vasquez-Roland, a Safe Haven Foundation, and I just want to just concur. I think this is a great idea, and I would, be very interested in volunteering for this committee. And I also would be remiss if I didn't mention the fact that, what HFS, what everyone has done, in the agency has just been like an amazing thing to see, and see the response to this COVID-19. So thank you for everything you're doing. I know it's been amazing. It's almost a year. I mean, it is a year, so, and I know, it's been nonstop. So I just want to thank everyone for everything you're doing. And I think this is a fantastic idea. I would love to help.
Madam Chair, Stanley, I'd just like to say just a few things. I too concur in full support. I think this is a wonderful idea. I did also just want to remind Director Cunningham that a couple of years ago, the MAC Quality did have a work group, an LT long-term work group, and we did spend some time on some recommendations, and we will be happy to supply that when and if this committee comes together. And any assistance that I might be able to offer, I'm more than willing to volunteer with that too. So full support.
Thank you. Thank you, Ann. Marvin, did I hear you?
Yes. And I just wanted to thank Director Cunningham for, Director Cunningham for talking about the pipeline, but I too would like to volunteer for the community integration. We in the behavioral health care industry, we've been working on similar projects, as you know, with Williams consent decree for some years now, and COBRA. So I'm curious, Kelly, how this might fit into that community integration.
I'm sorry, Marvin, how would what fit into community integration? You broke up just a little bit for me.
Okay, the Williams consent decree and COBRA.
Sure. Yes, I can address that. I think the Williams consent decree, Colbert consent decrees, and Liggett consent decrees, all driven by the Olmstead Supreme Court decision in the late 90s, certainly help to move the needle on community integration. And they lay out, I think, some very important premises and processes that we need to follow. But they don't cover everyone that I think would benefit from a transition initiative. They're actually quite specific in terms of how they defined their covered classes. So for instance, in developmental disabilities and LIGAs, individuals in state operated facilities, aren't subject to those consent decree requirements. In Colbert, individuals in nursing homes outside of Cook County aren't covered by those consent decrees. So I think what we're looking at doing is just perhaps including the Olmstead consent decrees, but talking about how we can cast a broader net. At HFS, we tend to, or at least try to focus on systemic reform where possible. And, with encouragement from Amber and other advocates, I think the time is right to look at this much more broadly across Illinois' population with disabilities.
Okay. And one question on the pipeline, will the data that is being collected now be shared with the committee?
We can definitely look at that, Marvin. I just saw a draft of it this morning. We're actually, it's relatively new, so we're just starting to put that together, but would be happy to share it, when we get it finalized. But wanted to let you know things were coming out of it.
Okay, thank you.
Well, so Director Cunningham, I would say that you've got definitely a positive response to this, and we would look forward to, as early as our next meeting, trying to potentially convene this group. One of the things I'd like to add to it as well is that we look at the information flows and any opportunities to streamline, where information comes in, how it's kind of put together, if you will, and presented. There's a common platform. I know there were sometimes people being intervened on by different groups, and there's a lot going on. And so we had a lot of activity, but not necessarily the productivity we're looking for when it comes to servicing folks. So, and keeping track of that. So information systems and any updates in the informatics part of this work, so that things come together, right? And we're becoming more efficient at delivering these things. So, but please continue. I do believe you have some other items as well.
I do. I'm going to talk just briefly and provide an update on COVID-19 activities by the department, but I had noticed one item in the chat, and I wanted to address that. We have an outreach in the chat from, I believe, maybe a case manager or a staff person named Veronica Lopez, who wanted a phone call back on a particular issue. I wanted to just share with her that we have seen her request, and I'll have staff give her a call back this morning. So I wanted to acknowledge that in case she is still on the line and listening. So my next update is going to be on COVID-19 activities undertaken by the department since our last meeting. I wanted to focus in just a few areas. I think all of you are familiar with our coronavirus website. link and see the numerous provider notices and pieces of information that we continue to refresh and to put out. But wanted to talk about a couple of new things. First of all, some staffing contracts. In response to concerns brought forward to us by public health and other stakeholders, HFS, and this was over the period between Thanksgiving and Christmas, worked closely with the State Emergency Management Agency to enter into some emergency procurements with healthcare staffing agencies so that we could help to supply hospitals that were struggling with staffing. That was a concern we had heard from hospitals. They were having trouble keeping staff on board, keeping staff to the levels of the surge that they were experiencing. So we were able to enter into these emergency staffing contracts and help to supply staff to needy hospitals in the Chicago and Metro East areas. Next issue I wanted to cover, no surprise, vaccines. Thankfully, we have a vaccine or two or three that we can talk about at this meeting. Wanted to share that we have been working really closely with the Department of Public Health, who's really the lead on this, with our managed care plans, providers, and other stakeholders around rollout of vaccine implementation. We have issued several provider notices on this, I think more specific to how providers should be billing administration costs, providers, practitioners, pharmacies, billing administration costs, but also have a couple of more provider releases in the works. Wanted to echo for everybody, no Medicaid customer should be paying for a vaccine. Under no circumstance, and we will be emphasizing that in a separate notice with our providers. It's free to Medicaid participants. The next thing I wanted to share was just about the vaccine administration payments. We have elected to use the Medicare rate for reimbursing administration costs associated with the vaccine. We're seeking federal approval to do that, but even absent federal approval, this is the decision we have made. And, the Medicare rate is a little bit more generous in terms of administration. And we believe that it's very important, first of all, to incentivize providers however possible to, be in the business of delivering vaccines, but maybe more importantly, we think this is an equity issue. We don't want providers or practitioners to be discouraged by a lower administration rate and that have any potential adverse impact on the Medicaid population. So for us, it was important, this was an important decision to use this Medicare rate. Just to help incentivize and reduce any potential disparities or equity issues associated with being a Medicaid customer in need of this vaccine. Next issue was the CARES funding. I did talk about this at the November meeting. We were kind of in the heat of the CARES Act funding distribution at that time. I had shared that we had brought on a contractor, Ernst & Young, or EY, as they processes to develop, to disseminate almost $800 million in federal CARES Act money that was appropriated to us by the General Assembly. I can share that through 3 application-based rounds of funding, over $700 million has been distributed to providers. Providers benefiting from that funding include long-term care providers, FQHCs, hospitals, physicians, behavioral health providers, and many others. So just wanted to share that the vast majority of that funding is now out the door in providers' hands and available for their use to offset some of the pandemic related financial difficulties, that they have had. The applications, how we responded to those was largely based on provider need. As they expressed to us in their application, there was an application portal built, and so a lot of staff devoted many hours to developing methodologies to move this money out the door. So wanted to share with that. And then I wanted to wrap up with just kind of assurance that from HFS's perspective, we want everybody to know we're working, closely with our counterparts at federal CMS, who are working with the new Biden administration, although we don't have a new CMS director yet, but we really are trying to stay tuned in to what is happening in Washington, D.C., through our National Association of Medicaid Directors and our Washington, D.C. office on issues around unwinding any of the flexibilities that we gained during the public health emergency. All signals from the Biden administration are that public health emergency is extending through this year, and that states will be given, ample warning, hopefully very ample warning, as we proceed to unwind any flexibilities, particularly around eligibility, redeterminations, new determinations, because we've been given significant flexibility in the last year. And if we have to just turn everything back on again, that's a lengthy, cumbersome process. We're also, hoping and working with our counterparts in other states to really encourage the Biden administration to make some of these flexibilities permanent, and not just related to the public health emergency. So wanted to just share that we've got our eye on that bigger picture, and are really advocating to maintain as many flexibilities as possible for our populations, or at least to get ample time to plan for any unwinding activities. So wanted to share that. The next issue I wanted to tee up, and Robert Mendoza is going to take over some of this discussion, but we have heard from many of you, MAC members and other members of the public and interested advocates, about concerns with Aetna's pharmacy network on the south and west sides of Chicago. I think there have been some recent news stories. We're getting a lot of questions about that. I wanted to ensure everybody that, we're taking, any issues about network adequacy very seriously in terms of our populations. We've worked very closely with Aetna on this issue. We're gathering data, having, in regular contact with them, and a representative from Aetna may be on the phone, as well this morning. But I wanted to turn this over to Robert to talk about a little bit further.
Great. Thanks, Kelly. And, and good morning, everyone. Again, I'm Robert Mendoza, Deputy Administrator with the department. Kim, before I get started, I have some comments to make. I want to make sure that our Aetna colleague is on for the question part. Is Tangela, I believe it was Tangela Feemster. Is Tangela, we were able to get her connected?
Yes, she is connected and on standby to speak, Robert. So please proceed with your comments.
Excellent, thank you. Just in terms of, I'm going to provide some background and what we've learned and some of the what we think of or what we want to do, we will be doing going forward. So, shortly after the acquisition of Illini Care by Aetna in January, Aetna did approach us and to tell us that they would be moving to the Aetna network, and that part of that would mean the termination of Walgreens from the network. They had provided some, extensive data research on access, And at that time, and we were using our access standards, which were national access standards, which were 15 minutes or 15 miles in urban areas. And so we did approve they were compliant with everything in the contract, and we approved it. We approved the transition. Worked closely with them. They did extensive member education. They provided letters to members saying there's 3 pharmacies, the closest pharmacies, offered to change the prescriptions into those pharmacies. We also offered free home delivery to extend to 90-day deliveries. And also the letters indicated that all members would have 90 days to change after the effective date to another plan should they choose. So all that being said, we felt that we did what we needed going into the transition. However, it wasn't until after go live, and in most instances, and I've been through many of these, it doesn't get real until it's real, and people aren't paying attention to a lot of the things, and we know that. And after the go live, we started to hear from providers of concerns, specifically in disproportionately impacted areas. So we did a great deal of drill down in that, working with Aetna, and specifically, around in the Chicago area where we heard a lot from. And I could get into details if you want, but we did find that specifically in those areas, access to pharmacies, and there was a lot of misinformation that it was just CVS. They had also contracted with a great deal of independent pharmacies. So finding specifically in these areas that there was access on average half a mile. And then every specific access issue that was brought to our attention, we were actively brought to Aetna's, and all of them were resolved, most of them proactively resolved, and we're going to continue to do that going forward. And I think one of the big lessons learned from my standpoint in the department is going forward, we'll really be looking at our access standards. And specifically as we look at everything, and as we talk about our quality strategy going forward, we want to look at everything through an equity lens. And to be quite honestly, that wasn't done in the past, and it wasn't done nationally. But clearly, something that we've learned through the pandemic is something that is going to be a major improvement in everything we do, is making sure we do look at everything through an equity lens. So we will be looking at all of our access standards, making sure that we're looking particularly at disproportionately impacted areas where people aren't able to drive, they rely on public transportation and other means, that there is access. So you have our commitment to that going forward. I will say in this situation, we are working closely with Aetna. We have resolved every situation that I'm aware of, and any specifics any facts that you have or anything that we need to do, we'll make sure to address it. And if the bottom line is the best interest of the member is to move them to another MCO, we will also facilitate that. So I will stop there. I don't know if Tangela's going to add anything. But then I'd like to open it up to questions.
Deputy Director Mendoza, you took a lot of my speaking points. Thank you. And thank you, Deputy Director Mendoza. Thank you to the Medicaid Advisory Committee. Thank you to the stakeholders who are tuning in. I'm excited to provide more information about Aetna Better Health of Illinois and our pharmacy network. We are absolutely committed to ensuring our members receive the medications they need when they need them. I'll be briefly covering 3 points. Some of them Deputy Director Mendoza has already touched on, and so I will, do my best to be brief and cover those points. But the first thing I'll cover is Aetna Better Health network adequacy as it relates to pharmacy access. Secondly, I'll cover Aetna's strategy that we have employed to help us meet the needs of our members living in and near pharmacy deserts. And thirdly, I'll be covering our member utilization habits. So with respect to network adequacy, as Deputy Director Mendoza said, there's been a host of misinformation about Aetna's pharmacy network. And so I'll begin by talking about the pharmacy partners that make up our network. Across the state of Illinois, we have approximately
2,000 pharmacies that participate in our network. In Chicago, on average, our members, as Deputy Director Mendoza said, live roughly 6 blocks away from one of 271 in-network pharmacies. These include pharmacies inside of Walmart, Jewel, Hy-Vee, Mariano's, Meijer, and Target, and a host of independent pharmacies. On the west side in particular, we have in-network retail pharmacies with an average distance ranging from 0.4 to 0.7 miles away from our members. Our network, and this is super important to highlight, is not limited to or reliant on CVS pharmacies. We are continuously reviewing our network to ensure we're meeting the needs of our members and maintaining network adequacy as required by the state and federal government. I know there's been some discussion about MCOs should mirror the Medicare Part D rules with respect to network adequacy. And so I thought that I would cover that. And so as a part of Medicare Part D, with respect to urban areas, it is saying that at least 90% of beneficiaries must live on average within 2 miles of an in-network retail pharmacy. With respect to suburban areas, that 90% must live within 5 miles of an in-network retail pharmacy. And with respect to rural areas, 70% of beneficiaries must live within a 15-mile radius of an in-network pharmacy. Well, Aetna Better Health meets or exceeds all of the state's access requirements as well as the Medicare Part D requirements, despite their lack of application to this particular Medicaid program that we're in. Why? The answer is because access to pharmacy services is important to our members' health. All right, so I thought it was very important to underscore that part. The second thing I want to cover is Aetna's strategy to help meet the needs of our members living in and near pharmacy deserts. I'll begin right off the top. We know pharmacy deserts are real. We know that we can't be everywhere. So when there are Aetna members who don't have access to transportation or who are experiencing safety concerns or mobility issues, we bring the pharmacy to them. Our strategy to address greater access for our members living in and near pharmacy deserts includes free delivery from many chain and independent pharmacies, free local delivery, leveraging our mail order pharmacies for 90-day prescriptions shipped directly to members' homes. And finally, with respect to our strategy, we continue to invest in community partnerships driving community-based solutions to address issues affecting social determinants of health, like pharmacy deserts. I'm going to hop into the last thing I'm going to cover, which is our members' utilization habits. With respect to our members' utilization, we've identified approximately 12,000 Aetna members spanning across Austin, North Lawndale, Garfield Park, and Humboldt Park neighborhoods. 80% of those members do not have a record of using medications, that's maintenance or periodically. Of the remaining 2,600 that receive medications, 1,900 use pharmacies, mail order, or long-term care facilities outside of their neighborhoods. We found that 800 of our members are utilizing pharmacies within their neighborhoods, with 55% of our members utilizing local community pharmacies. It's important to note that some of our members in that data I just shared are using pharmacies both in their neighborhoods and out of their neighborhoods. When examining trends in our previous network participation, we found that Aetna members have always supported a diverse set of pharmacies, including small business independent pharmacies in their neighborhood. As it relates to member complaints regarding network access to in-network pharmacies, we found that our historical trends as they relate to incoming calls are staying level. That's about 5% for us, and that is not out of the norm. It's directly in alignment with our historical analysis of our call volume. We have not recorded any increases in calls related to pharmacy network concerns. Further, we've not received any member grievances regarding changes to our pharmacy network, either directly or through alternative escalation routes. I want to highlight that we are happy to always help our members access services. Our member services number is 1-866-329-4701. And to wrap up, Aetna absolutely believes our pharmacy network exceeds state and federal expectations. We acknowledge that pharmacy deserts are real. We have a strategy to address our members' needs living in and near them. And finally, our data shows that our members are utilizing their pharmacy benefit and opting to support the small business community pharmacies in their neighborhoods. Their support of these pharmacies is an important long-term solution to addressing pharmacy deserts and stimulating the local economy. And I'll wrap up there. Thank you very much.
Thank you, Tangela. Dr. Huggett, do you have any questions for Tangela or Mr. Mendonza, Ms. Feemster or Mr. Mendonza on this issue?
Yes, Chair. Thank you. Thank you so much. First, I want to say thanks to the director for the focus on equity. And I think this issue is directly a focus on equity. Your presentation last MAC meeting, Director, really focused on, the third and fourth highest ranking zip codes were 60623 and 60624 on the west side. So this issue of pharmacy access that I'm experiencing as a family doctor at Londell Christian Health Center on the west side is certainly one that directly affects my patients. And, I really appreciate the input from our Aetna colleague. However, I'm a little concerned that information hasn't been received. Information regarding problems with pharmacy access has been conveyed to the department. One was on December 10th regarding Invega Sustenna, another one December 15th on sertraline and mirtazapine. That was from me, another from Heartland Alliance on December 18th regarding prenatal vitamins. They weren't able to access prenatal vitamins. On December 20th, a summary letter was sent to HFS. On December 28th, PCC Wellness notified the department about problems with access to Suboxone. On January 4th, Shawnee Health Services in Carbondale also let the department know about access to Suboxone and even OB's ultrasounds. So, we have been conveying this information to HFS. In reviewing the response, the December 30th response that Aetna had, it said that there were 44 pharmacies that served their 11,000 members in the 5 West Side zip codes. When we did a survey of those pharmacies, and I can put some of this in the chat that was released in the press release from Representative Ford yesterday, out of those 44 that were on Aetna's list, only 26 actually were available for Aetna Better Health patients. Several were closed to the general public. For example, one was an infusion center at Rush, one was a dermatology clinic pharmacy, one was an eye clinic pharmacy. There were duplicates. So it was really, when we looked at that list of those 44 pharmacies for those 5 side zip codes, it was only 26. When we look at those more carefully, and we talked about the distance traveled, when we look at those census tracts on the west side of the 116 census tracts, over 55% of those census tracts require people to walk more than a half a mile. 92% of folks on the west side do not have access to cars. This is a racial equity issue. There are no CVS pharmacies at all, 0 CVS pharmacies in majority Black West Side communities, 0. There are no CVS pharmacies in majority Black West Side communities. There are no CVS pharmacies in East Garfield Park, West Garfield Park, Humboldt Park, Austin, or North Lawndale. 0. In the network is included independent pharmacies, and I use independent pharmacies frequently, but we also have to realize that, if we want to really raise the equity issue, we really have to see what independent pharmacies can actually do to respond to the needs for our patients. So I guess my question, Chair, is moving forward, I'm really happy that Mr. Mendonza mentioned that this was going to be an issue moving forward, that equity is at the center of what the department does, that what is foremost, especially when coronavirus vaccine is being rolled out to Walgreens and CVS pharmacies, that there will be access in communities that are hardest hit. The West Side zip code of 60623 has the highest number of COVID-19 deaths in the city of Chicago. The West Side has the highest number of opioid overdose deaths. When we looked at those pharmacies, those independent pharmacies, 7 of them did not even have Suboxone in stock. They would have to order it. So we really question whether independent pharmacy, the network that is being there, is really serving our patients. So the question that I have, Chair, is what further things will the department be doing to address this equity issue moving forward for Illinois Medicaid recipients with Aetna Better Health, especially on the west side of Chicago, but really throughout Illinois? Thank you, Chair.
So thank you, Dr. Hug. I know this is clearly an issue that you've been in communication with the department about already. I wanted to, Ms. Feemster, I wonder if there's an opportunity. It sounds like there's this is not the only issue, right? But there's this Suboxone issue. I'm wondering if Aetna CVS be willing to do a little bit deeper dive on that access for that medication in particular.
Yes, Chairwoman Whitaker. And we had, and as Deputy Director Mendoza alluded to, we had been proactively pursuing those conversations. And so as Dr. Huggett teased out nuance there, we are affirming a nuance between provider escalations and member escalations. So in no way was I saying that we had not heard from providers with respect to our pharmacy network. Yeah. I was merely highlighting that we had not heard from our members. And if Chairwoman, if you would allow me just a little bit of latitude, please. Dr. Huggett, our December 30 letter only referenced 21 in-network pharmacies. That's a letter from our CEO, Kim Foltz. And so I would be interested in you sharing data with us with the pharmacies that you outreached. And so I'm happy to report that we have, in the zip codes that you're interested in, we have 25 independent pharmacies. There are 7 chain and grocery store-based pharmacies, and there are 11 clinic-based pharmacies. And those are pharmacies housed at hospitals, long-term care facilities that aren't generally open to the public, but they do serve an important role in servicing our members who frequent those locations. And so, we're happy to continue that conversation. But again, I just really want to clear up the misinformation and, set up another invitation to have a conversation with you about what our data actually demonstrates and to hear your friction points.
So I want to kind of stop this if you guys hear me out, because we do have quite a bit to still cover and we're 45 minutes left. So I think what I'm going to suggest, Ms. Feemster and Dr. Huggett, is that you all connect, because one of the things I can say about Dr. Huggett and the work they do at their health center is they really do know the community. And so just connecting with them, there's probably some just sort of things that are easily sort of fixed, Ms. Feemster, from your perspective, to connect the two things that are needed here. So I believe the data that you presented, I think we all do. Thank you for the diligence that you actually took a look at your network to see what was there and what wasn't. But Dr. Huggett and those guys are practicing in real time. So is there something that they could know better or, clear it up? And then if they don't have that issue anymore, these things, a lot of it will resolve. So I'm asking if you guys could connect, please. And let's take that offline to sort of do some problem solving. So in the interim, if we come back in 90 days, we should have this figured out, if not before. So thank you for the work, though, Ms. Feemster, the presentation and everything that's been done. And thanks, Dr. Huggett, for the diligence and kind of elucidating these issues. Can I go,
Chairwoman?
Yes.
Yes. Can I just make a quick comment? I just want to make sure I go on record.
Yes,
A Safe Haven is also weighing in on this, and there's actually been a bill filed by Representative Ford in regards to amending some of the Medicaid pharmacy access. I'll post it in the chat box in a little bit, but I do believe that it's going to be an issue about access standards and really revisiting those. And what Mr. Mendoza mentioned earlier is, I think, going to help, resolve many of the issues that we were having with not just Aetna, maybe some of the other providers as well that are not represented here. So I urge everyone to look at the bill and make some comments on it while it's in a draft form at this moment. So we're very excited about the possibility of really getting it to a place where we're going to hopefully resolve many of the issues that are coming up in the community on the front lines. We're also experiencing, not having the ability to access pharmacies for our population. We serve about 1,400 people on a daily basis that are either homeless, living in supportive housing, and seniors and veterans. So it's an important issue to us. We spend a lot of our time, trying to fill prescriptions, especially as many people are homebound. So please, pay attention, if you don't mind, to that bill when I post it shortly. And we're excited about being a part of this and hopefully getting to where we need to be. Thank you.
And so, so Ms. Beamster, I'd be happy to brainstorm with you offline, but it sounds like, you've got a number of mechanisms by which people could get their meds, including mail order and other things. So I'm wondering, we need to look at all the different capabilities that Aetna, in fact, does have to sort of close these gaps. And I believe they're there. So are there any other committee members who want to go on the record with anything related to this issue? Because we do need to move on.
Yeah, Dr. Whitaker, I do, because we have heard from some of our members when this happened. Me and Dr. Huggins have been in touch over the last few weeks because I wanted to know if he had, some problems with his patients. But we were hearing from people with behavioral health care issues from our members, not only in Chicago, but in Northwest, up in small cities up in the Northwest part of the state. And for them, it really wasn't about access, it's about choice. I mean, the community providers spent a lot of time and effort really convincing some people with mental illness that they need the help and that they need the medicine. And they set them up with a pharmacy, and they start to trust that pharmacy, and they come to really rely on, and it becomes automatic for them to go to that pharmacy. And when that is disrupted, then it's a problem. It's a problem with the agency, it's a problem with the person on Medicaid. Because then, like with some of our members, they reported, well, now a couple of their clients don't really want to go to that pharmacy and take the medicine. And these are people with severe and persistent mental illness. So I know Robert mentioned about access, but there's also an issue around choice. And so when we talk about equity, of course we're talking about race, but we also talking about disabilities too. So that's it. That's all I have.
Thank you so much. And thank the committee for their feedback on this issue. And I know that Deputy Director Mendonza, Ms. Beamster, will take this feedback very seriously and look to close the gaps on kind of what the issues are. There's kind of issues I think that can be tackled, and then there's sort of some bigger issues around choice. We're going to be considering all of those. Deputy Director Mendonza, did you have any other remarks? I know you're going to talk a little bit about maybe a couple other things.
Yeah, I can get into my updates. The only thing I'd say, and Dr. Huggett, I think your comments, about understanding what equity means, because I would lie if I told you exactly what I know. It means getting people what they need, but how that works in the real world as we evaluate things. So we will be engaging your expertise and many others on that as we all learn, because we are all learning what does it mean when we say equity lens. It's an easy thing to say, but it's something that we have to get proficient at and understand much better. And we're not going to do it alone, but working with our people who are in the community and really know this population best. And we'll make sure that all those populations are engaged as we understand and move forward.
I appreciate that, Robert. And I just want to say, this continues to the day. I got a phone call this morning with a person having problems getting their medication, getting their Suboxone. So, I understand that you're still working on it, but I really think that we should really consider a systemic solution rather than just saying, oh, we're just going to take care of this person and then this person and then this person. I really think that it's incumbent upon us to really, I really like to hear from the department if they're willing to provide a systemic solution to, like Marvin said, to preserve patient choice in terms of where they get their medications. Mail order just does not work for persons who are experiencing homelessness. Mail order does not work for people, or delivery does not work if their mailboxes are torn up in the hallway of their apartment building. It just doesn't work. And, I know that those are kind of theoretically good solutions, but, I really appreciate you saying that, you're going to be listening to people like so many that you've heard from that are working with our patients every single day. And we want to make, that's our goal. I'm not, we're not against Aetna or anything like that. We're just fighting for our patients. And we really want to join together in doing that. Thank you so much.
Thank you, Dr. Huggett. Director Eagleson, did you have a comment?
I had raised my hand at one point in time, but I just did want to say that the department is looking at systemic solutions. We definitely are hearing Suboxone as an issue in this case that needs further work. But we have committed to, I think you heard Robert say, that we're using national standards now on access, and we were already, before this issue came up, starting to look at those, and we will be sharing more and soliciting more from you all as we look at those in different areas across the state. So that's, I'll let you move on now. And I believe Dr. Goyle's on for the earlier agenda item, Dr. Whitaker, that you wanted to.
Okay, one more comment. Thank you so much. One more comment from, I've got Ann Lundy has a comment, and I have a comment, and then I'd like for us to try to move on topically. Ann?
I'll be very, very brief, but I just wanted to mention with Access Community Health Network, we have several of our integrated health centers that have a pharmacy embedded within the medical home. And some of them are independent, but we also have some with Walgreens. And I'm really pleased to tell you that we were able to work with Aetna on this issue because that PharmD, that's really a part of the medical team that's serving those patients that come to those health centers. And so even with the Walgreens, we were able to get an exception and keep them in network, if you will, in those situations. So I really highly recommend that you reach out and you work with Aetna on these, because again, the embedded pharmacies, whether they're independent or whoever they are, really are a part of that medical team working with the population.
Thank you, Ann. And then finally, I'd like to say, what I was suggesting earlier is that we take the Suboxone problem and use it to sort of see what the issues are. And it may be an opportunity to, again, address a number of the issues that we're talking about. So just I want to be clear on what I was saying there. It kept coming up, and wow, we can sort of go, like you say, you can go through the list of things that make getting this medicine a barrier. And I hope that Aetna CVS could take a look at that. It may actually, shed a light on several things that are important. So with that, Deputy Director Mendoza, are there any other comments? I'm going to move to Dr. Goyle.
No, Dr. Whitaker, we're good. Thank you.
Thank you so much. Dr. Goyle, you are here. Would like to hear from you on the opioid use disorder withdrawal management subcommittee update.
Yes, Madam Chair, can you hear me okay?
Yes, I can hear and I can see you. I can see your head.
That's wonderful. That's the most prominent part of my system here. And hopefully a little bit of sunlight. So I appreciate being connected. Wanted to give you a brief report in bullets. However, I would be happy to explain and expand as time permits and if there are questions. And but if the goal is to be sure that the committee understands and everybody who's on understands that the department has undertaken a lot of work in this area. So I want to start by thanking Kathy Chen for chairing this subcommittee, and of course, thanking the MAC for accepting those recommendations. We have moved forwards with them, totally in sync with the leadership of HFS, as well as other people in the agency and even the outside agencies, as you will hear in a moment. So what I did is took the recommendations and split them into three, because those recommendations weren't necessarily in those divisions, if you will, but to make it easier for us, the first point was more dollars for OUD providers. The second was evidence-based OUD treatment approaches and connection to ongoing community-based MAT. And the third had to do with 42 CFR2 SEMSA ruling. And I would talk about each of those for a brief period of time, but please stop me if I get too much into weeds. So as far as the more dollars part is concerned, I want to draw your attention to 4 things that HFS has done recently. One is 2% increase for all SUD providers effective July 1 of 2020. Secondly, DHS and HFS changing methodology and standards to reimburse providers effective September 1 of 20 in 3.2, 3.5, 3.7 facilities. These are the ASAM placement criterion facilities, which are lower than the hospital detox programs, as they are called, but they are residential anyways. And the aggregate cost modeling approach is the one that they are taking together. The third one is the opioid-related funding in Illinois. There is a list that is available from Super on a monthly basis. And in my detailed report, which we will include in the minutes, we will add the link in the February newsletter of the Super agency. And the last item on the dollars for OUD providers, I want to draw your attention to Support Act 1003. It's a demonstration grant award. We are in the study phase at the HFS. It's multi-million-dollar grant. And there is a second part to it. We will have to apply later this year for implementation. And if we get that grant, then there are dollars attached to it for SUD providers, more dollars, I should say. So that was the second part that I wanted to raise issue with. The second issue is evidence-based OUD treatment approaches, connection to ongoing community-based MAT. That is a slightly complicated issue because remember that the hospital part of it, the 4.0 facilities, are under the leadership of IDPH, and the rest of the residential facilities are under Super, and that is on designation by HHS. HFS leadership met with the leadership of those two agencies, as well as the Department of Human Services, and we learned exactly what I told you, that the hospitals have inpatient detox programs. These programs are utilizing medical surgical beds, and they have two types of surveys. One is when the Medicare agency, the CMS, asks that they be surveyed in total, and that hasn't happened recently, and or if there is a complaint, and then they can be reviewed. On the other part, the Super is consistently developing best practices. And I do not know exactly where the implementation is, but it is our plan to continue to work with those two agencies so that we deliver what was asked by this subcommittee.
Dr. Goyle?
Yes, please.
Can I give you just about 2 more minutes, please, just so
Yes.
that we are able to cover, and I know
Yeah.
you can provide perhaps a draft in writing or summary in writing.
Yes, absolutely. Thank you, Madam Chairman. Then I do want to talk about the guidance from Super and IDPH, and that will continue, and I can answer any questions if you have. We've developed outcome-based metrics. You probably are going to hear about that at this meeting or shortly after. Two of those are pay for performance measures, recent measures implemented by HEDIS people. These are still process-based measures. They will measure the follow-up after ED visits for patients with OUD. And the second one will be maintenance on MAT for OUD, for opioid use disorder. So I want to skip over to an item which is extremely important for this program at the HFS. We had a web meeting last month with all the CEOs and the chief medical officers or medical directors of our MCOs. And we informed them that it is HFS's desire that they do case management, care coordination, and transition of care for patients on chronic opioid therapy, patients on MAT, patients who are seen or treated for opioid overdose in any setting, patients who are admitted or discharged from inpatient detox units, and patients who are diagnosed in any setting with SUD, alcohol, cocaine, nicotine, marijuana, etc. Consistent with state law, they've also been informed that there should not be a PA of any kind on Suboxone, no single prescriber or single dispenser limits, and that counseling with MAT is a requirement of CMS. And then the last thing that I want to say is that the 42 CFR Part 2, SEMSA is currently working to mitigate the rule that exists. And along with the report, we will provide you a PowerPoint presentation from SEMSA on the rule to be sure that everybody understands what the rule still allows to do and what it does not allow us to do. So I would stop there, be happy to entertain questions as the time permits. Thank you, Madam Chairman, and I'm sorry for the difficulties in my connection earlier.
No problem. Any questions from the committee? Dr. Goyle, will you be drafting this for us in writing this update?
It's been written, there is a draft, and I will be happy to submit it for inclusion in the minutes, Madam Chair.
If you could.
Yes.
Are there any, I can take 1 to 2 specific questions, and I'd like to move to the quality committee, although very important update here. Dr. Huggett, I see your hand, and if you have something, hit me in the chat, guys, because I can't see everyone across the screen.
Yes, thank you. Thank you, Madam Chair. Thank you, Dr. Goyle. I'm just echoing what Dr. Kelvin McGinn put in the chat, that the costs did not go down for Medicaid recipients. And I am just wondering, I'm theorizing that part of that is because of the content and the expense of current hospital-based detox programs. And I think that that was kind of the core of that committee work that was chaired by Kathy Chan so ably. So the question for the department is the charge or the recommendation that was given to the department July 19th, 2019 was to create payment methods regarding detox, the former detox programs that would really not have a person detox, but stabilize on medication and then continue on. What is the department doing in that regard, regarding the change, regarding the motivation of the change of the content of detox programs? Thank you, Chair.
The best way I can answer, Dr. Huggett, thank you for the question. I also want to say that I had a conversation with Mr. McGinn recently about counseling part of it. As I did with ISAM, some of their members as well. And we've constantly updated the Opioid Advisory, Crisis Advisory Council on what we were doing in this area. In conjunction with IDPH, which monitors so-called hospital detox programs or withdrawal management programs more accurately, there need to be a few items added. These would be the best practices, so-called, and I barely referred to in my original comments. So what happens is that when a patient is admitted, they are usually admitted because they are either in withdrawal or they need to be sobered up. And I'm mentioning the usual words in a detox program. The sobered up meaning that they were intoxicated with either alcohol, opioids, or something else, or they had an overdose, and now we need to bring them back to a normal state. So what you need is really an evaluation, which could be summarized: medical, psychiatric, addiction medicine, etc. They need to be observed very closely and treated with appropriate medications. And if they consent and if they are appropriate patients for MAT, then they need to be started on MAT while they are there with a community provider linked up. We are working with the other agencies I mentioned in my comments, and we will hopefully succeed in the near future because that is within the preview at this time of IDPH. But we have good relationships. Dr. Azike attended the call, so did our leadership, and we had an excellent discussions. I would assure you that our director, Teresa Eagleson, Medicaid Administrator Kelly, and our Chief of Staff, Ben Winnick, we are all heavily invested. We have also a new person on our team who you might know, Eric Foster. He's worked in this space as well, and I think we look forward to his contributions as well. We will do exactly what you're asking as soon as we are able to do it.
Dr. Goyle, thank you. Dr. Huggett, thank you for your question. This is something that many of us care a lot about, Dr. Goyle, so we're going to be continue to ask about really payment reform around this issue. So thank you so much. I'd like to now take a few liberties with the agenda. The Public Health Subcommittee report and the Quality Care Subcommittee reports have been submitted in writing. They will be submitted to the record because we're not going to be able to get to a live presentation of those subcommittee reports. We want to move to the draft quality strategy. We have about 15 minutes slotted for them, and we'd like to have them come to the floor now. Our Medicaid Administrator Cunningham, Deputy Director Mendoza, and Ms. Wells are slated here on the agenda. But please, quality strategy. Thank you so much.
Thank you, Dr. Whitaker. This is Kelly Cunningham. I will be kicking off a presentation on the department's quality strategy. Don Wells is sharing the screen, so everyone should be able to view the slideshow as we go. So I wanted to, I'd like to think that maybe we saved the best for last here, and that is the opportunity to talk about the department's comprehensive medical programs quality strategy. Next slide. Wanted to kind of put this in context a little bit and take the opportunity to briefly kind of share some work that the department has done under the leadership of Director Eagleson, really around strategic planning and establishing a new mission for ourselves and getting our staff more involved in our mission. We improve lives. We value our staff. We're committed to always improving, and we inspire, public confidence. We're looking at doing this through social determinants of health, empowering customers to maximize their health and well-being, providing consistent responsive service to our colleagues and customers, and making equity the foundation of everything we do. And I share this because our strategic plan and our mission and our transformation work really are all embedded in this quality strategy. Wanted to, not sure, Dawn, are you able to make your presentation a little bit bigger? I think some individuals are having trouble reading the bullet points.
There you go.
Yeah, that's better. That's better. Thank you. Next slide. Oh, I see we have the speaker notes up on the slide too. So you all will get a little clue about what I'm going to. Maybe we can get those taken off, but no big deal. No big deal. And so the quality strategy is really based in the establishment of 5 quality pillars. We're using those quality pillars moving forward in 2021. And as I said on the previous slide, they are really kind of underpinning our infrastructure, both externally, in medical programs and how we approach our clients, our customers, our providers, but internally in how we work with staff. These quality pillars, I know this slide has a lot on it, but I'll just refresh those for you. Maternal and child health, there's been so much discussion about that. Adult behavioral health, child behavioral health, equity, we're making a pillar, and community-based services and supports. Oh, thank you. Kim, you can move to, I think, the third slide. So just a little bit of background on our quality strategy. Just to provide to you, this is a federal requirement. We're required to do it by the federal government, and it must align with the federal quality strategy and the broader aims of the national quality strategy. Next slide. Our purpose was really to define something that was transformative, person-centered, integrated, and equitable. We've had quality strategies in the past. Probably some of you have been involved or seen copies of those, but they have not really been transformative, nor nearly as person-centered as we'd like to make our current strategy. Our mission is really to improve people's lives by improving social and structural determinants of health. Wanted to just emphasize this is a new mission for us, by the way. You'll see it probably over and over again, but I think it's important to read it. We want to empower customers to maximize their health and well-being and maintain the highest standards of program equity on behalf of Illinoisans. And we are making equity the foundation of quality improvement. So my purpose with these slides is really kind of to stress that we are looking at our quality strategy systemically. I mean, this is going to underpin, everything that we're doing. And so we need to kind of always keep this first and foremost in our minds as we evaluate programs, as we evaluate the actions we need to take, as we evaluate our relationships with the legislators and with providers. We want to keep, and working with our managed care plans. We want to encourage you to adopt our quality strategy and to really keep it first and foremost. Next slide. Again, the emphasis is going to be on equity, prevention, and public health. We want to pay for value and outcome rather than volume and service. You've heard that from us for a number of years, but what we're really trying to do with the quality strategy is operationalize ways, to really get at those outcomes and improve those outcomes. We want to use our analytics and our data to drive decisions and address health disparities, which, we've talked about so much. And where there have been so many devastating health outcomes. And we want to work to move individuals from institutions to communities, keep people in least restrictive environments, keep them connected to our families and communities. And that, I think, relates back to that earlier topic we had on the agenda about creating the Community Integration Subcommittee. And some of our discussion about that and you as MAC members, robust support for that initiative. Next slide. So these are some of the federal goals around quality strategy: better care, healthy people, healthy communities, and affordable care. I'm not going to read each dot point. There's a lot on this slide. I'll also say too, we're in the process of getting ready to submit this presentation and our quality strategy to our federal partners. So we will absolutely make this available to all members of the MAC. We'll put this on our website. This will be a publicly available document. But these are going to be our aims and our goals. Next slide. Want to talk a little bit about social determinants. We have talked a bit about social determinants in previous MAC meetings, and I think we have actually used a slide very similar to this in some of our transformation presentations, but it never hurts to hit home again, that as important as clinical care is for our members and for our communities, it it is not the only predictor of how healthy an individual or a community is going to be. 50% of an individual or a community's health is attributed to social determinants, social, economic, and environmental factors. And those social determinants include things like economic stability, education, housing, transformation, food, support networks, safety in the home, any number of factors. And that is something that we are really trying to be more attuned to and incentivize and work with our managed care plans to recognize and to value for their providers. And to, as we move forward with our transformation program, create partnerships which really can address social determinants in addition to those very important, aspects of clinical care. Next slide. And again, just wanted to get our pillars in front of you again. We are establishing with our managed care plans, pay for performance measures and pay for performance, pay for reporting measures around each of these 5 pillars. For the first year or so, we may have to use pay for reporting, just enable us to establish benchmarks. But our goal is to move to pay for performance in these areas: maternal and child health, adult behavioral health, child behavioral health, equity, and community-based services and supports. And so I think this is my cue to turn the slides over to my co-presenters, Deputy Director Mendoza and Chief of our Bureau of Quality Management, Don Wells.
Great, thanks, Kelly. A lot of words on this page. I think I just want to reiterate, Kelly's comments on, we have pay for reporting measures this year, and that's because we are introducing new measures. Not all HEDIS, some, as you see, are going to be very much homegrown or just state specific that we think are really important to managing each of these pillars. And the key here, 80% of our customers are in managed care, so our managed care plans are going to be central to improving the population health, and they are going to be required to participate in all of our efforts to improve. And we believe that our P4P will drive the performance, and our P4 reporting will drive the performance that we want and improvements in outcomes in each of the pillars. And I think that one thing that I'm excited about as we continue to talk about things through an equity lens is looking at these measures in different ways. Not anymore it's a statewide measure, but I think we need to learn how to look at these from based on race, based on gender, and even more important, most importantly, by community. That can we look at various communities and see where there's disparities in terms of outcomes? We already heard some of the big disparities that exist. Can we focus on those and improve those? So that's the direction we want to move this in. We're working on an accountability measure with the plans so that we're consistently looking at these measures and looking for consistent improvement. We believe that each of these do support the pillars. And again, a lot of words here, but the point is that we're going to drive accountability, work with the plans, and improve population health, but it's going to be really specific to the needs of specific communities. Again, looking at everything from an equity standpoint. I'm going to next slide, please. So I'm going to start talking about the measures that will be implemented, both pay for performance and pay for reporting. The first pillar, maternal and child health. So we have prenatal and postpartum care, both the timeliness of prenatal care and postpartum care, and childhood immunization status. And then that would be the P4P. And then you can see here the pay for reporting measures. We've chosen 4 that we'll be monitoring. And as Kelly said, our intent is that we may have some continued pay for reporting, but over time, we want basically all these measures to be paid for performance. It's just important that we establish baselines and other measures so that we can truly measure increases in outcomes and performance. Next slide. For the adult health, So the two P4P measures are follow-up after hospitalization for mental illness and ED visit, 7 and 30 days. These have been measures we've used in they're HEDIS measures. So we'll continue those. We'll be establishing baselines. There's two new measures that are going to be paid for reporting, and that's follow-up after high-intensity care for substance abuse and pharmacotherapy for opioid use disorder. So those are two that we're excited to be monitoring. And again, these are HEDIS, but we have every intent to also drill down into various populations, communities, as we look at these measures and fine-tune areas of improvement. Next slide. On the children's behavioral health, again, we have the follow-up, again, HEDIS measures, but we're excited about these measures on the pay for reporting. As you can see them here, like one of them, mobile crisis response that results in hospitalizations, visits to ED for behavioral health. It's really the reduction of hospitalizations for behavioral health, and it's going to be, it's more than encouraging, but we're really going to be working with our MCOs to be partnering with community organizations to find more community resources to keep these kids out of the hospital for behavioral health, to, crisis stabilization, a variety of services to help these kids, to keep them from these behavioral health hospitalizations that lead to long hospital stays. So the area that we'll be focused on, and none of these are HEDIS measures. These are state-specific measures that we will be reporting on. And again, everything through, as I mentioned, the equity lens by various, slices by community, gender, what have you. Next slide, please. Then our equity pillar, and you can see our pay for performance measures, breast cancer screening, cervical cancer, controlling high blood pressure, and access to preventative care. And then you see our pay for reporting. We really centers around HIV. Next slide. And then the last is community-based services. And unfortunately, there's no good HEDIS measures, or we didn't have any good measures in the past that we can use for pay for reporting in terms of establishing baselines and what we would need to do. But we are implementing two pay for reporting measures that will be used, and it is our intent that if not 22, but certainly by 2023, that these would become pay for reporting as soon as we understand the results. It can set goals and baselines and for performance. And I think this is my cue to turn over to my colleague, Dawn Wells.
Hi, good morning. Yeah, just following up, Kelly and Robert hit most of the details on our quality strategy moving forward. I think I would just like to add that, the measures we talked about are just that. They're measures for us to gather the data. What's really going to be critical is what we do with that data we gather. What does it tell us and what do we do with it? That's going to be the critical piece to this. And as they both said, equity is center in everything we do. So we want to start looking at all these measures through an equity lens. The first one you'll see on the screen is improved maternal and infant health outcomes. We have the measures we're going to be getting data on, but our goal is to look at that data. What else can we do with that data to improve these outcomes? How do we reduce preterm births and improve the rate and quality of postpartum visits? That is so critical, is to get to these outcomes. Same with behavioral health. Improve the integration of physical and behavioral health and the transition of care. The equity lens is, to me, is one that I'm very passionate about. I've done a lot of research, and I think it was mentioned in the beginning that a Black woman is 6 times more likely to die from childbirth. They're also 6 times more likely to die from breast cancer and 2 times more likely to die from cervical cancer. So we have to look at those disparities. And I think when we're looking at those disparities and we're looking at that data, it is important to look at, geography and community. But the other real issue in that is trying to find the root cause. How do we find out what is actually causing these disparities? And I think as far as what we do with the data and how we get to some of those root causes, the vision going forward is to have routine quality meetings with the MCOs. And part of it will be discussing the numbers and the progress. But Anne can tell you, as I said during our MAC quality subcommittee, the other piece moving forward with these MCO quality meetings is to bring in people who are experts in their field to discuss best practices. As I told the quality group, you know, sitting in my office, I can do all this research, I can talk to everybody, but the people who really know what's happening and really know ways to fix it, those frontline people need to be part of our quality meetings as well. Next slide. So, you know, we talked about all of these initiatives. These are our key drivers, you know, our pillars, our social determinants of health, technology initiatives. What do we need to do to get all that data we need to accurately measure these outcomes? And we have a trained, diverse workforce in doing that, and a strong partnership and community engagement. Next slide. And I think the final thing is we have to work strategically with our partners to get where we want to be. It takes more than one bureau, one agency. We have to work together. You know, we need to work closely with Public Health, Department on Aging, DHS, DCFS, all of those other state agencies. We want to be part of this going forward. So I think, you know, working together, we all have one goal in mind, and that's improving lives and reducing disparities. And that's all I have.
Thank you so much. Very informative presentation. Exciting that this type of work is going on at the department. Will you be posting this to the website sometime soon? Director Cunningham?
Yes, we
Okay.
will. As I shared, this is, we plan to submit this to federal CMS very soon, and we will be sharing what we submit. So.
Okay, thank you very much. So we have 3 minutes left in our meeting. Certainly has been robust today, very full. So I want to, the enrollment eligibility and redetermination update, I'm wondering if, is that something that is on the website, Director Cunningham, that Ms. King can share with the public that way?
Yes, I think we can share that on our website or get a report out to the group.
Okay, thank you so much. The telehealth update, Ms. McCullough-Starks, are any sort of critical changes that have occurred since our last meeting?
No, Chairman Whitaker, no changes really substantial have occurred. Well, I'll just say that, you know, utilization continues to grow during this period of time, as we all can imagine. But in terms of change in the program and access to care via telemedicine, there have been no changes with respect to that.
I would like to just submit for the record that the 3 physicians that came on early in public comment, 2 out of 3 of them are physicians, they deliver babies, OBs, that one of the things that they're seeing is that the 3rd trimester is really not a place for telehealth, right? That those women need to be seen in person. So one of the things I think we need to do is to sort of take a look at where telehealth really makes sense and when it doesn't, what we do, right? So 3rd trimester pregnancy, we're talking about, you know, Southside Chicago and, you know, different outcomes, differential outcomes. So I think that's an interesting place of study. And I like to kind of put that on the table along with the many other things we're talking about. But this group of doctors could perhaps do like just a meeting with HFS perhaps in between here and the next time, just to give them some perspective on what they're seeing. Back to the committee, I want to first thank HFS. Subcommittee reports will be submitted in writing. Is there any new business, Ms. Phelan? I think we're going to have to defer your presentation. If you'd like to submit it in writing, you can to the next meeting. Is there any old business? I don't have any here on my agenda from our committee members. Any wrap-up comments?
Well done, Madam Chair.
Thank you, Mr. Peters. Did you have any comments otherwise?
No, I just think it's been a very productive meeting with a lot of things to cover. The department is doing some great work, and it's a good opportunity for us to learn more about it.
I think I agree, and I appreciate the amount of time you all put into preparing the presentations and the time. I mean, this meeting is really becoming more and more robust, and I hope useful to you all, as well as useful to the public. Any other committee members with wrap-up comments? We're at 12:01, and I know I could talk about this all day long, okay? So I want to be clear on that, but I do want to be respectful of everyone's time. So anything else from my committees before we entertain a motion to adjourn? Any other committee members?
Motion to adjourn, Madam Chairman.
I'll second it. This is Nellie.
Thank you. So moved. Thank you so much for our meeting. We look forward to seeing you again soon. I believe it's in June or May we get together again. So we'll be in touch in the interim, and may the good work continue. Goodbye, everybody.
Bye-bye.
Thank you all.